Yes,
Yeah, let
people
people
are
join.
joining.
Yeah.
So we can wait for another minute.
Yeah.
Should we start? Fine.
Yes, sir. I think we can start.
Smita, we are starting.
Snehal. I think today Snehal is there. So yeah, we can start, sir.
Yes, sir. Yes.
Yes. So, good morning, everyone, and warm welcome to today's webinar. As you all know, the cognitive neurology subsection of Indian Academy of Neurology has been holding webinars every month, but for last few months we have been struggling for some reason. So in month of June we could not organize this webinar. Generally in these webinars we used to have lectures from renowned experts from India and sometimes from international experts. So we are today fortunate to have Dr. Lawrence Soni from Columbia University, who has accepted our invitation. And you can imagine now it is midnight in New York. So thank you, sir, for accepting our invitation and for coming to this webinars. We are also fortunate to have Dr. Ratnavali, one of the senior neurologists and cognitive neurologists of the country, who will be chairing the session and will be moderating the session. So I hope everyone will learn something from Dr. Soni. Now I hand over this to my colleague, Dr. Fahim, to carry forward.
Yeah, thank you very much, Tanu sir, and good morning and a warm welcome to everyone for joining us today in this very important and timely webinar on advances in Alzheimer's disease treatment. Now, as we all know, the journey of clinical trials in Alzheimer's disease, it has been long and challenging, marked by hope, determination, and decades of scientific effort. And for years, patients and families that keep on asking us the most difficult question in our cognitive disorders clinic, that is there a cure? And while the answers were often uncertain previously, but today we find ourselves at a significant milestone that after nearly around 20 years of setbacks and learnings, we finally have FDA-approved drugs that mark a meaningful shift in Alzheimer's disease treatment. So this webinar is an attempt to shed light on this remarkable journey to understand how these therapies came into being, what they offer, and what lies ahead, especially in a diverse context like ours in India, where we have a lot of vascular risk factors. So we hope this session helps answer some of those difficult questions and brings clarity to the evolving landscape of Alzheimer's disease treatment. So we are truly honored to have with us Dr. Lawrence Honig, an internationally renowned expert with a wealth of experience in clinical trials, who will be sharing his key insights into these developments. So it's an absolute pleasure. And we are delighted to have you, Dr. Honig, with us today. Thank you very much for joining. And this session will be moderated by none other than Dr. Ratnavali, madam. She's one of the most senior cognitive neurologists of the country with an exceptional legacy in dementia care and research. Can you show me the CV slides, Snehal? I'll briefly introduce madam. This is a brief introduction. Otherwise, the CV is quite long. And Dr. Ratnavali, madam, has established India's first memory clinic at Dimhans in 1998. And she went on to pursue a prestigious Commonwealth Fellowship at the University of Cambridge in 1999. She has contributed significantly to both national and international literature, with one of her landmark publications on prevalence of FTD in Green Journal, garnering over more than 1,000 citations. She is also one of the co-founders of LMIC Working Group of Diversity PR within ISTART Alzheimer's Association and a member of the International Neuropsychiatric FTD Consortium as well. In recognition of her advocacy and leadership, she has recently been awarded as a Global Advocacy Leadership Program Award by the American Academy of Neurology in 2025. Congratulations, madam, for that. And madam's research interests span over risk and protective factors in dementia, frontotemporal dementia, bilingualism, and prime progressive aphasia. Currently, Dr. Ratnavali leads the Cognitive Neurology Clinic at Manipal Hospitals, Bangalore, and the Anaswamy Motherlayer Hospital Neuroclinic, Mysore. She also serves as an adjunct professor at the Manipal University. We are truly honored to have you with us, madam, today. And thank you very much for joining. So I may request you to kindly introduce the speaker and moderate the session. Over to you, madam. Thank you.
Thank you very much, Fahim and Atanu, for giving me this opportunity to moderate this session. Very important session, and it brings a lot of hope to our patients in India. And it's my pleasure and privilege to introduce Professor Lawrence Honig. Can I have his? Yeah, thank you very much. So we have a very distinguished speaker today talking about the disease-modifying treatments in Alzheimer's disease. And he's based at Columbia University, where he heads the Excellence for Center for Excellence for Alzheimer's disease, as well as other dementias, including Lewy body dementia. And so he has been a leader in the field of aging and dementia, and his research has spanned the whole gamut of neurodegenerative disorders and aging, from molecular biology, biomarkers, research criteria, pathology, genetics, clinical course, risk factors. And he's also been involved in the pioneer trials of the initial disease-modifying drugs in Alzheimer's disease, including bapineuzumab and solanezumab. So he brings a lot of experience in this era of which has changed the treatment of Alzheimer's disease. And, so we've had these breakthroughs in multiple sclerosis, and we await further disease-modifying agents in Alzheimer's disease. And it's very, very important. In India, we have a huge burden of dementias, as everybody knows, and it's expected to increase to much more. Currently, probably there are around 6 to 8 million people in dementia. So, and Dr. Honig has also won lots of awards, but unfortunately the CV has been shortened because it's too extensive. So, but he brings his vast experience to this talk. So the floor is yours, Dr. Honig. It's a pleasure to have you here.
Well, thank you so much, Dr. Ratnavali, for that introduction, and thanks to Dr. Tanu and Dr. Fahim. It's a pleasure to talk with you all in India. Hope to be there again in one of these days. My last visit was really a pleasure getting to meet so many Indian neurologists interested in cognition and behavior. So a pleasure to talk today. I will review where we are with Alzheimer's disease, particularly with regard to treatment. As you, I know you're all quite knowledgeable, but I'll sort of give you a summary and some up-to-date aspects of our treatment with the new treatments.
Snehal, can you stop sharing, Snehal, so that Dr. Honig can, yeah.
Sorry?
No, please carry on. No, sir, nothing, sir.
Can you see the screen okay?
Yes, yes, we can see the screen. Yeah.
Okay. So I will go on to my disclosures. I do always like to point out that I do consulting for a number of firms and have research, as Dr. Ratnavali mentioned, that's been spanning some years with clinical trials in a variety of diseases, and much of that is sponsored by pharmaceutical industry. For a group of cognitive neurologists, I don't think I have to point out that dementia is a deterioration of intellectual function, and that not all dementia is Alzheimer's disease. And these first few slides, first dozen slides or so, I'm going to go through fairly rapidly because I think you're all experienced. And it's more just to give you the framework by which I view the disorders that we all deal with. So, of course, dementia by definition is chronic. Though sometimes it be more or less rapid. It's not a specific diagnosis, but most importantly, even though most dementia is Alzheimer's disease, not all is. And that's very important when we think about treatments, because obviously when we have specific treatments, we only want to treat the correct disease with the specific treatment. As Dr. Ratnavali pointed out, dementia is common and increasing. These are the figures in the US. We expect over the coming decades to have tens of millions of people affected with dementia. And as she pointed out, the figures in India are very similar, that in the over age 85 group, which, with the increasingly good medical care in India and elsewhere, there's more and more people in that group. Unfortunately, dementia can be as high as 25 to 50% prevalence. And it spans all the states of India and all groups, unfortunately. Dementia is also part of a continuum, and I think you're all well aware that there are various words for people who don't seem to be really that impaired, but who feel they're impaired. And I'm sure you in India see many such patients, just like I do in New York. But there's also people who have mild cognitive impairment that's clearly impairment, but preserved function. And many of those people have Alzheimer's disease as a pathoetiology, and we do find that it's worthwhile treating them in the studies. Likewise, mild dementia is an appropriate criteria for treating with the new treatments. Unfortunately, we don't have any treatments right now for moderate or severe dementia that are disease modifying. Dementia symptoms you're all familiar with. I'm still fond of this very old slide, which points out that there's memory loss, language problems, behavioral problems, and terminal problems. But putting it more academically, of course, we have amnesia, aphasia, praxis, and agnosia as hallmarks of Alzheimer's disease, along with executive dysfunction. There's also behavioral changes that unfortunately you're probably all very familiar with, because these are often the symptoms that bring patients to us. And they may occur at any stage of disease, including even in the milder stages. Things like sleep disturbance, delusions, irritability, and such. And of course, there's functional impairments. We were just chatting about the traffic in Bangalore, and we have traffic everywhere. And unfortunately, a motor vehicle driving impairment is definitely a feature of cognitive impairment, and that doesn't make the traffic any better. But there are, of course, other things that are also clear markers of functional impairment, even in people who may not do so badly in some of our basic cognitive tests. You all have some similar scheme of evaluation to this. Key in the evaluation of a patient with a memory complaint is the history, And then the examination. And of course, the examination must include mental status testing, which as neurologists, we all know, but sometimes some of our colleagues in other specialties may not be as familiar with. Neuroimaging is really important nowadays because it's the first step of trying to come to the underlying etiology of the dementia disorder. Basic laboratory testing used to be more important, but at this point, very often, the basic laboratory testing is a box that we're simply checking and unlikely to be yielding. It's very rare that most of us see a case of undiagnosed hypothyroidism or true B12 deficiency causing dementia. Although, of course, low B12 status is quite common. So how do we really decide if somebody has Alzheimer's disease or one of the other conditions? Well, it's biomarkers, whether fluid biomarkers or imaging biomarkers. And at this point, even though many of us were trained in interpreting neuropsychological testing, that's really becomes only subsidiary or less useful because it's still not specific. Whereas the fluid biomarkers and imaging biomarkers are much more specific for telling us what the etiology or cause of the dementia is. Again, the symptoms sometimes help us a little bit. Clearly, Alzheimer's disease is often a memory-dominant disorder. But I think you're also familiar that in many younger people, and we do see lots of people who have dementia or impairment who are under the age of 60, for example, and in many of them, they may have more atypical presentations involving language or vision. But in general, whenever there's language impairment, one should consider the possibility of frontotemporal dementia. Likewise, when there's prominent behavioral impairment, one should consider that disorder. And of course, with some of the movement problems, we consider other disorders. But ultimately, it's the biomarkers that's going to help us because all of these conditions and all of these symptoms may overlap and concomitantly occur in a complex assortment. What is the bottom line? I think the statistics are really rather similar in India and Europe and the US and Asia, East Asia. Overall, when you look at dementia over the age of 50, the vast majority is Alzheimer's disease. But there's a significant minority that's Lewy body disease or Parkinson's disease-associated dementia. Frontotemporal dementias, which are very important category of disease, represent a relatively small proportion of people with dementia, although it's a larger proportion in, for example, the age 40 to 60 group compared to the age 60 to 90 group. Vascular cognitive impairment is something that was diagnosed right and left in past decades and is still often a diagnosis that we may get, a referring diagnosis from internists, for example, is actually really quite rare. At least in the United States, but even in places like East Asia, where there used to be really rampant cerebrovascular disease, vascular cognitive impairment is less common by far than Alzheimer's disease. Then, of course, there's scattered other diseases that we don't want to miss, and likewise that we wouldn't want to use an Alzheimer's treatment in somebody who had one of these other disorders. Of course, what marks the disorders and the reason why the biomarkers are so important is the proteins that are involved. So amyloid is the principal actor in Alzheimer's disease, although tau is also has marked abnormalities, whereas Lewy body disorders, the second most common cause of dementia in the elderly, is marked by alpha-synuclein deposits and also by some amyloid deposits in many people. TDP-43 and prion are involved in less common disorders. So it's amyloid, tau, and neurodegeneration in Alzheimer's disease that mark the disease course. Amyloid first, tau second, neurodegeneration third, temporally in that order. And there's a sequence that we see. And we can see that now with modern biomarkers, both imaging and fluid, that amyloid abnormalities are first evident, then tau abnormalities, and then neurodegeneration marked by shrinkage of the brain and the emergence of neurodegenerative markers such as neurofilament and and GFAP. So Alzheimer's diagnosis and treatment. You know, at this point, it's really a very different world, as Dr. Ratnavali and pointed out, and Dr. Fahim. And basically, Alzheimer's disease diagnosis can be made with biomarkers. And this diagnosis is exceedingly important because they're drugs that in many parts of the world are available. And I do understand that lecanemab, at least, is under consideration by the Indian regulatory authorities, according to the news. And you may well have it in the near future available, at least at some level. These disease-modifying therapies are antibodies. There's two of them, lecanemab and donanemab, that are approved in a number of countries. At least lecanemab is approved in the US, the United Kingdom, the European Union, China, Japan, Hong Kong, Macau, Korea, Israel, UAE, and probably other countries by now. So it's really available throughout many countries in the world. Some of them have different rules about its use and the eligibility of persons. And some of them have different rules about insurance coverage or payer coverage. So there's issues, but these antibodies are approved by regulators in all these places because it's clear that the antibodies do work at slowing Alzheimer's disease. And this is indeed revolutionary because up to this point, the last few years, we did not have any treatments that slowed down Alzheimer's disease. All we had were symptomatic treatments. So in the remainder of this talk, I'd like to talk about the disease-modifying drug development process, how we got to where we are, and then a little bit about how the treatment's going in the trials and now in clinical practice over the last few years. So who should be treated? How do we initiate treatment? How do we monitor treatment for safety? And as I mentioned, this may be, I mean, already you probably have patients asking you because there are lots of people in India who get around and news-wise and into other countries. And I expect that you may have the drug available to prescribe with whatever criteria and limitations might be provided in your nation. Already there's quite a few differences, for example, between UK and EU versus the US. But okay, let's talk a little bit. Alzheimer's confirmation is key, because if we're talking about treating with Alzheimer's disease therapies, those therapies do not work for frontotemporal dementia or pure Lewy body disease. So we need to have biomarkers. We need to know what the person really has. And the amyloid imaging biomarkers are very useful. The amyloid and the phospho-tau CSF markers are very useful. And increasingly, plasma markers in the right situation can be fairly informative, although they're not quite as good as the spinal fluid. Spinal fluid, this just shows that it's been around for a while. This is a review that a fellow wrote with me almost 20 years ago, and already we knew the basics, which is that A-beta 42 goes down, total tau goes up, and phospho-tau goes up in Alzheimer's disease. And this is a pattern that's fairly distinctive when it's present in its classical form. It's been the basis of a number of commercial tests, and here in the United States, we have several of them. Two of which use all three of those markers, the Roche-based ECL test and the old ELISA-based immunotest. But both of them have the same idea, which is that although they have completely different numbers or reasonably different numbers, but the idea is that when the A-beta 42 is going down and the tau is going up and the phospho-tau is going up, then that's a sign that it's Alzheimer's disease. But plasma is also turning out useful. And as many of you may have seen in the news, the first plasma test for Alzheimer's disease was actually the first one to be FDA approved, actually came out last month. And it, performs reasonably well, although it has 22% indeterminate test results. But if you ignore the 22% that are indeterminate, the sensitivity and specificity are above 90%. So that's what I'm going to say, I think, about biomarkers for the most part for diagnosis. Talk a little bit now about the how we got to where we are treatment-wise. You know, the disease, as you all know, was first recognized in the very early 1900s by Alois Alzheimer, and named maybe 10 years later, but really didn't become clearly in people's consciousness as the principal cause of dementia till the 70s, till the 1970s. And then there was a succession of criteria over the last 40 years. And there's been a succession of treatments. The first 5 treatments were all acetylcholinesterase inhibitors, or NMDA active drug, and they did have modest effect in improving the symptoms of Alzheimer's disease. But it's really been a whole succession that Dr. Fahim alluded to, succession of trials of drugs to intervene with the Alzheimer's amyloid process that has resulted in the current 2 proven medications and a number of other ones that are in the pipeline. Dr. Cummings, my good colleague, every year puts out a drawing like this, a nice mandala, and it just tries to show all the different treatments in phase 1, phase 2, and phase 3 of different categories that are in the pipeline for Alzheimer's disease treatment. And of course, only a handful of these are approved drugs, and we just talked about them a moment ago. And this is another way of looking at them. We have symptomatic, non-specific drugs such as neuroleptics, antidepressants, anxiolytics, and sedatives, which you're all familiar with using on a symptomatic basis to go and make patients and their families more comfortable so that they're not seeing, you know, tigers in the house, and things like that. And so that they're sleeping at night. Then we have the symptomatic specific drugs, donepezil, galantamine, and rivastigmine, of which I believe all 3 are available in India as they are in the US. And these are acetylcholinesterase inhibitors. We also have memantine, which is only of some utility in people with moderate to severe Alzheimer's disease, but is an NMDA glutamate receptor drug. But now, of course, at the bottom, we have lecanemab and donanemab, 2 drugs that remove amyloid and prevent its deposition, or at least lecanemab prevents its deposition, and have been of great utility in slowing down the course of Alzheimer's disease. So as you all, you know, increasingly recognize, Alzheimer's disease is a slow and progressive disorder. Of course, when you see somebody with cognitive symptoms, you know they didn't start yesterday, even if they first noticed them last week or something like that. The fact is that it's a very slow process, and these molecules in the brain, you know, increase in quantity and increase in the injurious effects on the brain over many years. And it's in general, when you see a person who notices the first symptoms, it's likely that they had the beginnings of the process biochemically at least 10 or 15 or 20 years before they came to you. And that's why it's important to recognize and take seriously people's cognitive complaints early, because we have treatments that are effective in the mild cognitive impairment and mild dementia stages. So the therapeutic strategies in general have included, you know, knowing that amyloid is the core feature of Alzheimer's disease, the earliest feature and the one that seems to cause the tau and the neurodegeneration. It was reasonable to think about decreasing amyloid production. It was reasonable to think about decreasing amyloid fibrillization into these plaques. It's reasonable to try to increase clearance of the amyloid through active or passive immunization. And as you know, the 2 drugs that are approved are passive immunization methods. These are antibodies that work against amyloid and clear out the amyloid and bind the amyloid and prevent more plaque formation, at least in the case of lecanemab. There's interest in treating tau, and I'll only briefly talk about that. And there's other treatments that we also hope might end up of use, including drugs that might decrease neuronal injury or protection. But just to very quickly go through some of these, decreasing amyloid production has been tried with a number of agents: beta secretase inhibitors, gamma secretase inhibitors, gamma secretase modulators, and unfortunately to date, for reasons that are not clear, decreasing production, or agents that should decrease production anyway, because we don't always know exactly what's going on in the brain, have not been effective in slowing the progression of Alzheimer's disease. And in fact, a number of these drugs, the beta and gamma secretase inhibitors, have actually had deleterious effects on people's brain function, at least on a temporary or transient basis. Likewise, the drugs that you can imagine that trying to prevent aggregation of a molecule is not so easy, although it's had some, these strategies have worked a little bit in some of the other amyloid disorders, such as cardiac amyloid, but in the brain, it's not been an easy battle. And the drugs that have been tried to date haven't shown clear efficacy. So it's the anti-amyloid trials that resulted in the drugs that have shown clear efficacy and some of the more promising ones in the pipeline. The first treatments, as many of you know, were active immunization, and that was the original experiment in mice, which I'll show you in a moment. But then after that, passive immunization seems to be the mainstay of our trials. As I mentioned, tau drugs have been tried, and the only one that shows relative promise at the moment is antisense strategy, which we don't have time to talk about today. And I guess I have a few slides in here about drugs that don't work, such as all the substances that people buy in the general stores. We have things called general nutrition stores, and people buy all these things because they come with a promise of some hope. But again, it was the anti-amyloid strategy that's resulted in the drugs that work. It was first shown in mice. This is a mouse on the left trying to swim, and it can't find the maze because it has some Alzheimer's itself. It was genetically engineered to have Alzheimer's disease. But it turned out that when you immunized mice against amyloid, and it was really a rather striking result that was discovered in the late 1990s, very late 1990s, that when you did that, the mice didn't accumulate as much plaque, and they did better behaviorally in the maze test that you see here. It was rather quickly translated into active immunization trials, which had striking side effects of meningoencephalitis and were terminated, and then to passive immunization trials, with the first one being bapineuzumab, which was at this point over 20 years ago. And it did actually show evidence of clearing amyloid a little bit by PET scan. We already had PET biomarkers, but it showed no clinical efficacy. At least as used. It did, however, show us a new brain condition that we were previously unaware of, which we term amyloid-related imaging abnormality, or ARIA. And ARIA-E for edema or effusion, or ARIA-H for hemorrhage, were clear side effects of this drug, suggesting that the drug maybe was doing something because it was causing this new side effect in the brain. And that has been key to understanding the further development of these drugs. We don't know exactly why the ARIA occurs, but we believe it has to do with the interaction of the antibody with the amyloid, not in the parenchyma, but the amyloid in the blood vessels, in the amyloid angiopathy that's so nearly universal in Alzheimer's disease. So while people with Alzheimer's disease have, of course, amyloid plaques and amyloid deposition in the parenchyma, in the tissue of the brain, they also almost all have some degree of deposition in the small arteries of the brain. And we call that conjunctival amyloid angiopathy, or CAA, cerebral amyloid angiopathy. And we believe that the antibodies reacting with that amyloid cause weakness of the blood vessels and bleeding or edema. Some people thought, well, maybe you could try any old immunoglobulin, and that didn't work. But the specific immunoglobulins, as I will go through, eventually did show clear efficacy. And solanezumab was another antibody that was tried, and which I was the principal investigator on. That was an antibody against soluble A-beta as opposed to bapineuzumab. Each antibody interacts with different forms of amyloid. It has different properties, and it's for that reason that we probably had a number of failures before we had successes. Solanezumab showed a little tiny bit of efficacy on a whole bunch of scales, but not on the primary scale. So it was not on the primary outcome scale where it did not meet clinical significance. And interestingly enough, it did not remove amyloid from the brain by PET scan. Aducanumab did clearly, like bapineuzumab, but even more dramatically, remove amyloid from the brain in a dose-dependent manner. You can see that when you go up in the dose from 3 to 6 to 10 milligrams, there was a marked amyloid clearing in the brains of people over 1 year. And in placebo, it was the opposite. They got more amyloid in 1 year. So very impressive biomarker clearing. The clinical results were a little bit less impressive. It was on the market for a while in the United States, but it was withdrawn from the market because it did not have full FDA approval. It just had what we call accelerated approval, and the other drugs came along which had full approval. But it did show some efficacy by a variety of biomarkers, not only amyloid clearance, but even tau and tau biomarkers. I won't go through the detail. But it also showed ARIA-E and ARIA-H, and it showed and we got a much better idea of the time course of that ARIA-E and ARIA-H, which occurred over some months, but usually in the first half year of treatment. And again, the ARIA-H is little tiny hemorrhages. The ARIA-E is edema. And I'll show some more pictures later on. Donanemab is an unusual antibody which only interacts with the amyloid in plaques itself, as far as we know, although it must interact with the amyloid in the blood vessels as well, because it does cause significant amounts of ARIA-E and ARIA-H. But we do not believe it works against the lower molecular weight species that are forming the plaque that the lecanemab also works against. But donanemab did show impressive plaque clearance, impressive biomarker efficacy, and impressive, even on phase 2, clinical slowing, somewhere between 20 and 39%, depending which measure one used. In the phase 3 trial, this was proven more clearly that there was clearly an efficacy, a clinical efficacy of slowing the progression of Alzheimer's disease, whether one looked at the CDR sum of boxes scale, the combined strain scale called the iAddress, or the activities of daily living scale, or a typical neuropsych ADAS-COG scale, looking at thinking and memory aspects. And when one did sensitivity analyses, it seemed like it didn't really matter what kind of patient you were, whether you were younger or older, or male or female, or of one race or another race, or of one, or even severity or ApoE carrier, the drugs seemed to work. And these sensitivity analyses are very fraught because you're dividing the pie, if you will, tinier and tinier. And it had significant side effects, but most of them occurred in the first 6 months. And that included a significant number of deaths and serious adverse events. Lecanemab, the phase 2 study, again showed very clear dose-dependent efficacy. You can see that as one goes from placebo to higher and higher doses of the drug, there was more and more effect at reducing amyloid. There was also more and more effect at reducing phospho-tau, signs of tangles, and signs of even neurodegeneration, neurofilament light chain. It was very clear that there was this efficacy in the phase 2 study, and that resulted in more in phase 3 studies, which I'm going to go on to. So the phase 3 Clarity AD trial of lecanemab showed in a couple of thousand people, 1,700 to be precise, 1,795, that there was clear efficacy of this drug and that the side effects were manageable. I'm going to go through that in a little bit more detail. So the efficacy really was clear. After even a few months, the lecanemab and the placebo curves diverged in a clinically significant, statistically significant manner. The PET amyloid clearance was very clear, and the change in the course of the disease was reflected in not only the cognitive scoring, the activities of daily living, the combined sort of CDR scale, and even other scales such as the ADCOMS, another additive scale like the iAddress I referred to earlier. And of course, there were side effects, just like with the other drugs. And we'll talk a little bit more about those in a few minutes. But the major side effects were infusion reactions, which were manageable and virtually never severe, and ARIA-E and ARIA-H, which sometimes were symptomatic and sometimes severe, but overall were manageable. So these are just the numbers. I won't dwell on them. I should point out that just like the amyloid was cleared and just like there was clinical efficacy, there was biomarker efficacy. So pretty much most biomarkers that one looked at showed that as you looked over time in people treated with the drug versus placebo, the biomarker pattern looked more normal in people treated with lecanemab and looked more like Alzheimer's in the people treated with placebo. So you can see these, significantly diverging curves, whether we're talking about total tau in the CSF, plasma p-tau 181, plasma A-beta 42 to A-beta 40 ratios. Really, regardless of which biomarker we used, we saw clearly separation of the placebo and lecanemab arms. I think I already showed the adverse events. Just like I showed you with donanemab sensitivity analyses, the same sorts of things have been done, dividing the pie tinier and tinier into different groups. And again, some people try to make a great deal out of that. For example, when you divide up the pie in certain ways, some of the lines may cross the null point. But in general, you can see that in every case, for CDR sum of boxes and for ADAS-Cog, in every case, I think CDR sum of boxes, there was one case where the median point was not on the favoring side. But in the ADAS-Cog, every single median point, at least, is on the favoring side. So there's not a lot of reason to believe that Hispanics versus non-Hispanics, or females versus males, or younger people versus older people are more or less good candidates for the drug. There is reason to believe that for people who are milder, the drug might slow down the disease progression more. And that came out for both lecanemab and for donanemab. And I may show some slides of that or may not, depending on the time here. But again, it did the sensitivity analyses regardless of whether we're talking about activity of daily living, cognition, which I just showed you, or CDR sum of boxes, all showed the same basic phenomena. The question emerged, as to why over 20 years did we have some drugs that didn't seem to work, and then these last few drugs, aducanumab, lecanemab, and donanemab, did work. Overall, there's a clear relationship reasonably clear relationship, I should say, between the amount of amyloid PET clearance and the amount of efficacy. So even drugs that didn't work, like gantenerumab, the graduate 1, graduate 2 drug, and aducanumab, which sort of worked, was controversial, they all can be put onto this plot, if you will, and you can see that those drugs which had the greatest amyloid clearance, presumably the greatest activity against amyloid, were most efficacious. That doesn't necessarily mean that the clearing of the plaque is what's causing the benefit, but it does show us that the drugs that are more active at clearing the plaque are also the drugs that are more clinically beneficial. In the case of lecanemab, for example, it may well be more beneficial through its binding of the lower molecular weight species. But again, it does clear plaques, and the drugs that clear plaques more do seem to have greater efficacy. They also have greater side effects, and this is just a comparison of the 3 drugs that did achieve it on the market in the United States: aducanumab, the first one, lecanemab, the second, and donanemab, the third. And you can see that of these 3 drugs, they all have ARIA-E and ARIA-H, but the lecanemab has the least, and aducanumab had the most, and donanemab is in the middle. So we'll talk about that in the next few minutes, about some of these aspects. And the other thing that's very clear is that at least in the population tested, which was principally white, but also included a significant number of East Asians, that at least for lecanemab, that there's clearly an ApoE effect, that people who do not have any ApoE4 alleles have a much lower risk of ARIA-E and of ARIA-H than people who have 1 or 2 ApoE4 alleles. Actually, the major risk is having 2 ApoE4 alleles, and that's why the European Union and the UK have declined to license the drug for treatment in homozygotes. So, speaking of the European Union and the US, this is the product labels right now, which is that for lecanemab, the FDA says it can be used in people who have MCI due to Alzheimer's disease or mild Alzheimer's disease dementia, that you must confirm that they have Alzheimer's disease by amyloid confirmation, although the package insert does not say how you have to do that. And most physicians in the United States, most neurologists are using either PET scanning or spinal fluid testing, but very few are using blood testing at this point because it's not quite as good as the other 2. This package insert does say that because of the danger of ARIA-E and ARIA-H, one must have a baseline MRI and MRI treatment monitoring over the first 6 months or so, and that dosing should be paused or stopped depending on the severity of any ARIA that might develop. For the US, ApoE genetic testing is recommended but not required. For the EU, it's required, and homozygotes are not eligible. The EU in general, the European Union, has decided to make the eligibility more restrictive than the US. And China and Korea are more like the US, have allowed physicians more judgment to apply their own judgment with patients as to what risk patients might accept or not accept. So in the last few slides, I'd like to just tell you about the clinical real-world use. So I told you how we got to the point of getting these 3 drugs, now 2 drugs on the market, and showing that they clearly are efficacious, but clearly have side effects. And talked a little bit about what the label looks like. So what have we done with that? And the answer is that, at least at our center, we've treated over 230 patients at this point in time. About half of them under my direct care, and the other half under the care of 9 other neurology providers at our center. And unlike some of my colleagues who've made a very complex setup and been very reluctant to offer it to patients, and very fearful of the relatively low side effects, but that nonetheless can be significant, we've been relatively broad about offering it to patients and discussing with them the risk and allowing them to decide if we think they're eligible, whether they would like the drug. So we've similarly, we haven't been too directive about where they should get it. They can get it at any infusion center. They don't have to get it at our infusion suite. And we've used dozens of different MRI sites and dozens of different infusion sites, and had many different payers and from many different areas, rural, urban, etc. So Some of them have been on anticoagulation. Some of them have had pacemakers. Some of them have had strokes, bleeds, immune disorders. And again, if the package insert didn't exclude them, we didn't exclude them. You may know that some of my colleagues have decided to put out their opinions about what they think is appropriate or inappropriate use of these new drugs. But those criteria are not real criteria. They're made-up criteria, not to be mean about it. They're just their opinion that this is what they propose. In fact, the package insert allows these patients to be treated that would not meet the, quote, appropriate use criteria of some of these groups in Europe and the US who have put out such criteria. So the question is, can one safely do it according to the package insert, regardless of various practitioners' opinions? And the answer is yes. Our patients have varied in the from age 35 to 90, and have been men and women and all different APOE genotypes, including 12% homozygotes for E4. Various CDR.5 or CDR1, that's MCI or dementia, and various MMSEs, some of them with quite low MMSE, but still deemed mild. We have used CSF and PET, and in some cases both, for eligibility. And in the cases of both, sometimes one marker was not as clearly indicative of Alzheimer's disease as the other. And so we did, but if we were persuaded that the patient had amyloid confirmation, then it was reasonable to offer them the drug. So we've done over 4,000 infusions at this point, and had infusion reactions in about 15% of cases, so similar to the clinical trial experience, not worse. Some people get chills or feel hot or feel cold or feel headachy or fatiguey or have nausea or vomiting and diarrhea even. Don't understand that exactly, but these are the sort of systemic effects that we sometimes get with administration of lecanemab. But they're mostly the first infusion or the first two, and they're not serious. We performed close to 1,000 MRI scans, and they've gone smoothly. We've seen ARIA-H and ARIA-E, and I'll show you that in a few moments. We've only had one patient who died on treatment, and they did die from the treatment. They got status epilepticus from, despite the best monitoring and best treatment. So it can happen, but that's 1 out of 230. There's ways of classifying ARIA-E, and as we are going low on time, I will only point out that you can have radiographic severity and clinical severity. There's some cases that are severe radiographic severity, but clinically asymptomatic. And likewise, there are some cases that are pretty mild radiographically, but have clinical severity. So there's not a perfect correlation, like in most brain diseases, like in strokes, where there's silent strokes and strokes that can be very symptomatic, even though they don't look so impressive in size or dimension. The package inserts for lecanemab and donanemab in the US, but also even in Europe, look rather similar in the sense that if a person has no symptoms and only mild ARIA-H or ARIA-E, it's okay to continue dosing. If they either have moderate or severe radiographic severity or have symptoms, we tend to suspend dosing. With the one exception of people who have mild ARIA and mildish symptoms, sometimes we continue treatment without suspending it. So what are the sort of concerns in the treatment? Well, in general, for patients, bleeding sounds worse than swelling, but actually swelling or ARIA-E is much more likely to be symptomatic and is the thing we're really concerned about. So that's what I'll show you in a moment, and what we see on flare sequences. Bleeding, unfortunately, can rarely be catastrophic, but that is exceedingly rare, well less than 1%. So ARIA-H or bleeding is generally asymptomatic, The other thing that's important is that RAE swelling resolves, whereas RAH, once it occurs, bleeding in the brain, we can see the residual on the susceptibility weighted imaging in the brain, usually forever. It doesn't usually resolve. Regardless, the symptoms of RAE do resolve over some months, and the radiographic findings resolve over some months. In general, RAH, as I mentioned, is asymptomatic, but RAE is also asymptomatic in about 3/4 of cases. Only about 1/4 of RAE that we see on the MRI is symptomatic in terms of the patient noticing headaches or seizures or weakness or language change or vision change, depending where the RA is. So what does RA look like? Well, pretty graphic sometimes. This is a case of RAE, which you can see in the right posterior temporal lobe and even going into the parietal occipital lobes. And well, initially the RAE didn't have any RAH associated with it. You can see that by 41 days or 6 weeks time, there was significant RAH in the same region as the RAE in this case. And that is not uncommon. This is just two different sections of the same person's brain, showing that the lower level and a higher level. And you can see that there is this really marked swelling of the brain bilaterally, but more so on the right posterior temporal, left of the screen. Here's another case, not quite as dramatic, but equally quite dramatic. There is a lot of swelling here, this time in the left parietal occipital, frontal parietal occipital area. And again, RAH happens to occur in this case likewise. But you can see that at 3 months' time, that massive swelling has completely disappeared and there's no trace of it. You would look at this brain and you wouldn't think there was anything wrong with either of the posterior sides. You do, on susceptibility weighted imaging, see that there's some hemorrhages here that weren't there at baseline, which I didn't show here. Then RAE can be even more mild. I don't know if you see it here, but this is the baseline scan. There's a little bit of white matter disease. This is subtle RAE. Again, you're getting the picture that typically RAE often occurs in the posterior regions of the brain, whether the posterior temporal lobes, the parietal lobule, or even the occipital lobe. And again, there's swelling, and it goes away over 3 months. And then sometimes there's really, really subtle swelling. I don't know if you can even see it on the slides here, but there is some subtle swelling, this time here. So you can see that the sulci look a little bit different here and here. And even when you compare the left side with the right side, that there's some subtle RAE here, which was present after the 4th infusion, which was not present at baseline, and was still present 6 weeks later, but was pretty much resolved by 2.5 months later, and even fully resolved subsequently. So that just shows you ARIA from really massive bilateral ARIA to really very mild unilateral ARIA. And overall, we saw the ApoE effect that was seen in the studies, which is that people who had an E4 allele were more likely, particularly if they had two E4s, but really there isn't that much difference between E3 E3s and E3 E4s. And you can see in this particular, at this particular time point, actually we had a little bit higher percentage in E3 E3s than E3 E4s. So the big difference is really in the homozygotes, who clearly have an increased risk of RAE as well as RAH. But it's still, only 20%. That means 80% of people didn't have any RAE at all. And remember that of these people who had the RAE, still only 1/4 of them were symptomatic. So we're talking about relatively safe treatment if you monitor it and obey the package insert rules. Okay, so how do we do it? In the last few minutes, lecanemab is a single infusion every 2 weeks of 10 milligrams per kilogram, a single dosage, but that's weight-based. There's no titration. And as you may know, the subcutaneous administration of this drug is has been under investigation now for a few years. And the FDA is considering whether at least might be delivered subcutaneously rather than intravenously, at least perhaps after 18 months. We do a baseline MRI and 3 treatment period MRIs. We consider ApoE4 testing, and at this point, we really encourage it quite widely, just so we go in with eyes wide open. Anticoagulation is allowable. There may be a mild contraindication. We didn't have a chance to cover it, but thrombolytics are strongly contraindicated. So the biggest way, easiest way to have a patient die with lecanemab is to give them TPA or TNK, to give them a thrombolytic. And sometimes they appear in an emergency room with that amount of edema. A stroke neurologist might think that it's a stroke and give them thrombolytic, but that can be a lethal error. Donanemab, very similar, but it's a little bit different. It does require titration. It's a fixed dose that's not weight-based. The label recently changed, so the current label is that they're supposed to get 350 milligrams the first infusion, 4 weeks later 700, 4 weeks later 1050, and then 1400 milligrams every 4 weeks. It's only a 30-minute infusion. There's 4 MRIs instead of 3. And again, very similar in terms of anticoagulation, thrombolytics, and ApoE4. The one difference with donanemab is that we don't know that the drug works after the amyloid plaque load is no longer visible. So that puts us in an awkward position. And some people, at that point, first of all, when do you check that? When do you do a PET scan? You can't do PET scans every week. And the other thing is, once you do seek amyloid clearance, most patients still want, of course, an anti-amyloid drug, so then they have to have lecanemab. So a little bit of an unusual drug because the drug only works against the plaques, and it's not clear that there's any efficacy once the plaques have cleared. So who should get disease-modifying treatment for Alzheimer's disease? In the last few minutes, we'll go over this. Obviously, they have to have Alzheimer's disease. The stage should be early because that's the only stages in which we've tested these drugs. And again, the indication are that the milder cases may actually have greater efficacy. Amyloid confirmation is essential. We're not going to treat people with an anti-amyloid agent for Alzheimer's disease if they don't clearly have evidence that Alzheimer's is causing their symptoms. There's MRI eligibility criteria. If they have too many microbleeds or too much siderosis, we don't consider them. There's ApoE4 testing consideration, and simply the only role of that is to convey to patients and practitioners what the relative risk is when making a decision, knowing that the risk of a REE or RAH is greater when you have E4 homozygotes and somewhat greater when you have E4 heterozygotes. There's a number of issues that come up that are related to this, which is how do you do amyloid confirmation, CSF, PET, or plasma? I discussed that earlier a bit. Exactly what sort of MRI, and exactly how you look at the risk of the ApoE. There's administration issues. As I mentioned, it's intravenous treatment right now, and so you have to have an infusion center. And the patients have to come in every 2 weeks for lecanemab or every 4 weeks for donanemab. There's access issues. Some people don't have good IV access. There's infusion issues, but those are generally, again, only on the first 1, 2, or 3 infusions. So to summarize, where we are right now is that there were 3 antibodies on the US market, 2 of which are still on the market, lecanemab and donanemab, and they improve the PET biomarkers, the CSF and plasma biomarkers, and clearly reduce clinical progression of disease over an 18-month period. We have long-term data, which of course is not placebo-controlled, showing that it's safe, these lecanemab for 7, 8, 9 years, but we don't, of course, have clear data about the clinical efficacy after 18 months because we don't have placebo controls. All we have is things like historical controls, which do suggest continued clinical efficacy, but is not the gold standard of a placebo-controlled trial. So beta amyloid clearance therapy is the first and only strategy that has showed efficacy. There's marked amyloid clearance and modest clinical efficacy with, as I mentioned, something between 20 and 40% slowing, depending on the drug and the scale, perhaps as high as 50 or 60% slowing for people who have really very early disease for both donanemab and for lecanemab. But not 100% slowing. In other words, the disease is not stopped in the tracks, nor does it reverse disease. And of course, that's what my patients want. It doesn't make them back to normal. What about future therapies? Well, there's a lot of non-amyloid there's other amyloid therapies that are coming down the pike, but also there's non-amyloid targets, tau, ApoE, TREM2, neurodegeneration that I alluded to briefly before. There's genetic therapies of various sorts, and there's other still therapies and combined therapies that we don't have time to talk about today. But there's a lot of important investigations ongoing. We're not at the end of the road with these 2 approved therapies, but we do certainly have a very different landscape of treatment offerings to patients who present with mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease dementia. Thanks so much.
Thank you very much, Professor Honig. That was a brilliant exposition on anti-amyloid therapies. And I think it must have been fascinating for you as a clinician because you started seeing patients with impairment, then you had biomarkers in your lifetime, and now you're treating them successfully with anti-amyloid therapies. It must be very wonderful to see that in your lifetime. I think it's absolutely brilliant. So we have a lot of questions. So are they supposed to ask, or it's just I'm supposed to moderate? Can they raise their hand and ask for him?
Ma'am, you can only take up those questions, ma'am. I mean, you can only ask those questions and Dr. Honig may reply.
So before I go on to the questions, I have one comment. So I know you have alluded to this in your talk. So what do you say to those critics? Because there is a lot of criticism about the role of amyloid in Alzheimer's disease. Some of them talk about Alzheimer's disease as a syndrome, not as a disease. It has got multiple facets to it, and amyloid is only one part of it. And we should we should understand the mechanism better, and we should have more therapies. So I'm sorry to start with a controversial thing, but
No,
stirring the waters a little. Yes. Can you comment, Dr. Honig?
Thank you for that question. Indeed, I think, there were a lot of naysayers or for a variety of reasons over the years. I think the evidence is incontrovertible that amyloid is the beginning of Alzheimer's disease. We have such good biomarkers now with PET scans and blood tests that clearly show that amyloid is first, and then in terms of injury in Alzheimer's disease. Not that you can't have tangles without amyloid, but in Alzheimer's disease, amyloid is first. We have the genetic evidence, which is most powerful. And now we have this treatment, that the only treatments that work are drugs that interact with amyloid and clearly don't interact with anything else. So I think there's no doubt that that the amyloid antibodies are effective. Some people say they aren't as effective as we would like, and we all agree with that. But the idea that it's somehow some sort of ruse, some sort of clearly these drugs work. These drugs work a lot better than a lot of drugs we use in clinical practice. A lot of cancer drugs or ALS drugs, they work much better than anything like that. Compared to riluzole for ALS, this is much more impressive. And compared to a lot of treatments we use for cancer, this is much more impressive. Is it as good as our asthma treatments or our multiple sclerosis treatments? No, but it clearly, and there are a lot of people who had sort of built their life, experience, the professional life experience on saying amyloid wasn't the answer because they had some special idea that it was a virus or a bacteria or Lyme disease or something else. But I think it's clear that, and if it wasn't clear before the therapies, it's clear now. So I see some of these questions too. Did you want to?
Yes.
Did you want me to go address them, or did you want to mention them?
No, I will talk about it. There are lots of very prominent and senior cognitive neurologists on the call as well. And Professor Suvarna asks you whether, so it's very relevant question for India because we don't have amyloid PET and CSF biomarkers are not widely available. So do you think we should build capacity for both of these, or do you think the plasma biomarkers will replace?
Well, I think, I think that's a great question. PET is certainly, requires a lot more effort with cyclotrons and radiation, and not everyone has PET scanners. As you saw from our data at our center, we mostly did CSF testing, and CSF or plasma, of course, is the same test biochemically. Obviously, CSF requires the efforts of us neurologists or practitioners, whereas plasma, we just need a phlebotomist. I think plasma testing may be okay when it's an absolutely classical presentation for Alzheimer's disease and the markers are absolutely clear cut. But other than that, there are a lot of people who aren't so classical for Alzheimer's disease and the biomarkers aren't so clear cut, or both, one or the other or both. We know that people with Lewy body disease frequently have concomitant Alzheimer's disease. We know that people with other conditions can have Alzheimer's changes. We know that Alzheimer's disease positivity in the 80-year-old range is something on the order of 40%. So without any symptoms at all. So I think we have to be careful with blood markers in terms of engaging on years worth of anti-amyloid therapy just on that basis. But I think we'll be doing that. But meanwhile, CSF is easy, and you have a lot more confidence when you have the CSF biomarkers.
Okay, thank you. Thank you very much. There are other questions regarding especially people who have genetic Alzheimer's disease with biomarker positivity. So what is your take on giving anti-amyloid treatment to those who are pre-symptomatic but who still don't have symptoms?
Well, we get a lot of, genetics or not, we have a lot of people who are pre-symptomatic, particularly now that the blood test is available. A lot of people come to me and say, I have Alzheimer's disease, I'm still working, I want treatment. And the problem is we don't, you can understand their attitude. There's every reason to believe that if the drug works better and better in milder and milder people, that the people who are so mild that they don't have symptoms, it may well work. On the other hand, we don't know the circumstances of that, and it's under investigation with the A345 trial and other trials. So we will have that answer eventually, but in the meantime, it's a challenge. The insurers in the United States do not pay for it, and it's not per package label. It would be off-label usage because the label is only for people with mild cognitive impairment or mild dementia, not people who are asymptomatic or pre-symptomatic. But you can certainly understand why it's medically reasonable to think about it, and that some people might be willing to pay for it if a practitioner was willing to prescribe it. The good thing about those people is that the risk is probably less. So, it's not like you have more risk, but less benefit. I mean, so the less amyloid you have, probably the less risk you have as well. And so they probably don't have a lot of risk of treatment, but obviously no one should be getting treatment every 2 weeks intravenously if it's not efficacious. So, and we don't have proven efficacy in that group.
So I think that we don't have data on this, but can you address this question about how long do we give therapies, and also how long do the benefits last? So somebody has asked whether it continues to benefit or they are diminish or plateau. I think you briefly mentioned about that.
Yeah.
So can you take that?
Yeah, I was almost going to put up some slides. Thank you for that question, and thanks for those introductory remarks on it. So we know through the long-term extension data from the phase 2 study that we have data that goes beyond 7 years of treatment. So clearly there's no new abnormal safety signal that emerges. Likewise, from the whole host of data with all 3 drugs, we know that over time, the risk of RAE and RAE in particular, and drug-related RAH really goes down dramatically. So it's really very uncommon after 6 months of therapy to have any symptomatic side effects from these drugs. So we know it's safe. In the case of both donanemab and lecanemab, and aducanumab for that matter, we only have placebo-controlled trials that went out 18 months. So we do not know for sure what the continued efficacy is. The makers of donanemab, Lilly, have suggested that there's no efficacy of their drug after the amyloid has been cleared radiographically. So many people are stopping donanemab, although we haven't yet had it on the market for 18 months, at some point. That being said, obviously their Alzheimer's disease doesn't stop. It's just that the drug no longer is effective because the target molecule, the particular form of amyloid that the donanemab is directed towards, is no longer there. So it's not reasonable to expect that the drug is efficacious. But that doesn't apply to lecanemab, where the target form of the molecule for the drug is still there, and that is the protofibrils and oligomers. So even though the amyloid may be equally completely cleared in a person receiving lecanemab, there's every reason to continue the treatment. And that's why the long-term treatments have been going on for many years. The only data we have for efficacy in the period beyond 18 months in humans is historical controls using ADNI controls, Alzheimer's Disease Neuroimaging Initiative controls that are carefully matched. And there, the curves do suggest that there's a continued benefit beyond 18 months out to 3 or 4 years. We don't have data beyond 3 or 4 years for that. But that, of course, is not the same as a placebo-controlled trial. So we don't have proof that after 18 months, there's continued efficacy. But knowing the mechanism, there's every reason to believe that there's continued efficacy for lecanemab, even if there may not be for donanemab.
Okay, thank you. So I think that there are other questions because in India, there's very high prevalence of vascular risk factors and there is vascular dementia. And you've highlighted the exclusion criteria very clearly about, more than 4 microhemorrhages and more than 2 areas of superficial cirrhosis. So I think that we have to be very careful in the Indian setting because some patients can still have mixed dementias. And
Yeah.
Mitaba Ghosh also highlights this he's a very senior cognitive neurologist as well. He highlights this aspect and he also asks about the person who died in your study. So can you highlight the baseline MRI and the APOE status of the patient? If you remember offhand?
Okay, I'll address the second part first. So that particular patient who died did not have any microhemorrhages at baseline and did not have any, they were an E4 homozygote, so they were at higher risk, but they died because they had status epilepticus. Not the ARIA was no greater or lesser than a lot of other people's ARIA, just that unfortunately the particular location of their ARIA in the temporal lobe resulted in status epilepticus, and they went into the ICU and they died. Maybe they could have gone to the ICU and not died, but unfortunately they did die. Again, I wasn't directly involved in the care of that patient, but they were from our center. In general, I think the problem with hemorrhages, as Dr. Ghosh recognizes, is that they may be due to amyloid angiopathy or they may be due to hypertension, as he alludes to. And we don't really know. There's no particular reason, for example, to believe that a hypertensive hemorrhage is really a risk for RAE or RAH. We just don't know. We don't have enough data. In the studies, no one who had more than 5 microhemorrhages, at least on a GRE or T2 star sequence. And we didn't do SWIs in the studies. So we didn't do the more discerning sequences. But no one who had more than, who had 5 or more hemorrhages was allowed in the first place. So we don't really know. But I think that Dr. Ghosh is correct that one should be more cautious in people who have siderosis or microhemorrhages. And the product labels in the US and Europe and other countries do indicate that you shouldn't treat people who have either more than 0 or 1, depending which label we're talking about, area of siderosis, and more than 4 microhemorrhages. That being said, certainly there are people being treated off-label with more, and it's not really so clear what the risk is. We think that the way it works, at least from the biology, because you can ask risk 2 different things, and this comes up all the time. One thing is biological plausibility, and the other is the evidence. So I just talked about the evidence. We don't have a lot of evidence because we didn't treat people with more than 4 microhemes who had 5 or more. The biological evidence is that the RAE occurs when there is amyloid angiopathy. So to the extent that they have microhemes or siderosis due to amyloid angiopathy, that is a risk for RAE. To the extent that they have, for example, siderosis due to a pre-existing subarachnoid hemorrhage, we wouldn't expect like trauma, which I have patients who are included. We would not expect that would influence their risk of RAE or of RAH. So it really depends. But of course, it's not always easy to know that, whether something's due to amyloid or hypertension or trauma. In the case of trauma, we often know that they had the hemorrhage due to trauma, but we don't know that that's a risk.
Okay, thank you. So there's another question which asks whether there's any difference in the cognitive or functional status of patients with ARIA versus those without.
Great question, and that great question, and that was clearly a concern. Is that okay? It's great that the ARIA gets better, but are these people better off or worse off for their ARIA? And the answer is that this has been looked at fairly carefully for both lecanemab and donanemab, although there are some limitations because sometimes people drop out. But best as we can tell, the people with the ARIA did not do better and they did not do worse. They were the same as anyone else. You could argue that patients perhaps with ARIA would do better because that indicates that the amyloid is being cleared. You could also argue that maybe they did worse because there may be subtle injury. Again, the biological argument that maybe there's subtle injury there in the brain that we can't see anymore, but that could have occurred. But the clinical evidence is that they did not do any worse or better on the basis of the ARIA that they had.
So there is one more question which you also mentioned, that there are lots of families who are very concerned and they want this treatment to be given to the patient. So there have been several off-label uses even in India, even for mild to moderate disease in the absence of biomarkers. A couple of patients have had CSF biomarkers, but not everybody. And so Dr. Ramshekhar also asked that in your tables, there were a couple of patients who had normal CSF amyloid or p-tau levels. So I presume they had the positive PET, I presume. I don't know. You can clarify that. So he's asking the same question: in the absence of these biomarkers, do you think we should go ahead and give the treatment based on just clinical and MRI evidence, and that we're suspecting possible Alzheimer's disease, but there is no biomarker proof, and we have ruled out other subtypes of dementia to a reasonable extent? So can you please elaborate, Dr. Honig?
So while I've tried to say that, in our practice, we've been rather broad in our treatment, I would not go that broad. So I would definitely not treat anyone who didn't have proof of amyloid in their brain as the cause of their Alzheimer's disease. So you're absolutely right that there were a few patients, Dr. Ramshekhar is right that there were a few patients, and that's why I put up that table, who had rather not clearly abnormal levels of one or another Alzheimer's marker, and either their overall biomarker pattern was significant for Alzheimer's disease, or they had positive PET, or both. So we did not treat anyone who didn't clearly meet criteria for Alzheimer's disease when you looked at the whole data set. But and I think, fortunately, there aren't too many of those people, but if somebody has normal CSF amyloid and p-tau, it's overwhelmingly likely that they do not have Alzheimer's disease, and they shouldn't get treatment with the Alzheimer's medications. There's no, role for it. It's Is it going to hurt them? Probably not, because, if they don't have amyloid, they're not likely to get RAE or RAH. But it's like treating somebody who doesn't have cancer with a cancer medicine. It doesn't just because they want it. We don't do that. We don't treat people with chemotherapy just because their mother had cancer. We only treat it if they have cancer.
And it's too expensive also to do those experiments.
Yeah, I agree. It's a waste of resources. Our resources as physicians, the pharmaceutical resources, is also a waste of resources. But more importantly, it's just not the right thing to do medically, to treat somebody with a drug for a condition they don't have.
So
Just
then,
wanted to add to this question,
yeah, sure.
Dr. Lawrence. So now, given the growing availability of these biomarkers, so you think if we add plasma biomarkers at least to this MRI and clinical data without having a amyloid PET or a tau PET, do you think it's still feasible to give these therapies? Because amyloid imaging may not be easily feasible in every center in India if at all these drugs come up. Do you think still with plasma biomarkers we can give these drugs?
Well, I mean, first of all, if you can do plasma, you can do CSF because it's the same test, So I think first of all, that would be you don't need PET, but plasma and CSF are both biochemical tests. So it's just a question of doing the spinal fluid or not. The broader question is sometimes plasma levels of some marker enough? Maybe, but as I mentioned, only in cases where it's absolutely classical Alzheimer's disease with memory problems in the right age group and no evidence of any other disorder, and the biomarkers are strongly positive in the plasma, then I think it's reasonable to think about it. And my colleagues at WashU have treated a few patients meeting those criteria. I have not. We've always demanded CSF or plasma or both. But again, I realize that in India you don't have the PET resources often, and even the US we don't have them often, many areas. But on the other hand, CSF for plasma is the same. I mean, the only difference is whether the neurologist has the time to put a needle in and take out some spinal fluid. There's no, the test is a biochemical test for the same markers regardless, and it's just a matter that the CSF gives us so much more information than the plasma. The CSF, we have 3 markers which really reflect on amyloid, tau, and neurodegeneration status, and that's very helpful. Whereas in the plasma, we can be sometimes deceived, and there's a large number of people who have peculiar results in the plasma. Now, the plasma test may get better and better, and I may not be singing the same song as they say 2 years from now, but at the moment, even with our best plasma tests, it's not as informative as the cerebrospinal fluid.
Thank you, Dr. Honig and Fahim,
Yeah.
because I think Suman also had the similar question. So I hope it answers your question, Suman. Atanu, were you going to say something?
Thank you, Dr. Honig, for excellent talk. But in India, we are very concerned about the people. They are eager to give this therapy, even despite not having the biomarkers and the PET scan available here. And even some of the patients, their children want the patients to be treated when they are not in the mild stage. They're in the quite late stage because they have the money to spend, and they want the drug to be given to their parents. So what do you think in those situations where the disease has advanced from the mild stage to moderate stage? Is there any role of giving this anti-amyloid therapy in those patients?
Yeah, no, I understand, and I've had some people from South Asia myself come over for this question, and of course we have people from America, or natives also asking the same question. So we do appreciate the cultural issues and the fact that it's also pan global. The same. So the question is a good one. What do we do with people who are moderate or severe disease? And again, I'm pretty liberal about following the package insert, and maybe even sometimes stretching it a tiny little bit, as we talked about clinically. But really, I think one can make a good case that we should not offer, no matter how much resources they have, to people who have moderate or severe disease. And the argument is that A, we have no evidence that it's efficacious, and in fact, the evidence that we do have suggests there's greater efficacy with people who are milder than people who are even, who are mild cognitive impairment than mild dementia. And then B, more importantly, even if we don't have that, they say, well, so what if it may not work? We still want to do it. But the problem is that we have evidence that it may well be much more unsafe. So not only do we have a problem that we don't have any proven efficacy in that group, but we also have no clinical evidence, but biological plausibility. Again, I'm making that divide. We have clear biological plausibility that it would be particularly unsafe in those individuals because people who are more moderate or severe have more amyloid load, period, and have more amyloid angiopathy. And so the risk of cerebral hemorrhage and cerebral edema is most likely larger. Most likely because we don't have a lot of evidence. We don't have people who have been published that have been treated. But biologically, we're quite certain that those are factors that increase risk. So, we'll have other treatments for them, hopefully, but it really doesn't make sense to expose their family members to that risk, particularly knowing that there's no evidence of efficacy in that setting. I realize it's very tantalizing. It's like, the fruit on the other side of the fence. You look at that mango and you want it. It's very hard for people. They know they have the disease. They know there's a treatment there. It's just not the right treatment for their form of the disease. So all the more reason to encourage people to come to us neurologists earlier at the risk of overwhelming our clinics. But we'll have lots of new and younger neurologists who'll be taking up the mantle, right?
Yeah, I think that's very important that it's good that you've highlighted the earlier they get treated, the better is the prognosis, both from evidence and experience of many clinical investigators. So I think that's very important. And maybe we should improve the awareness and make an early diagnosis. So I think we have only a few minutes probably. So if we can just address the last questions very fast, if possible, Dr. Hornig. So there's a
Sure.
question about, does amyloid deposition increase the burden of cerebrovascular disease associated hyperintensity as a marker of surrogate axonal degeneration?
Yeah, that's a great question. Again, we do think that much of the white matter disease that we see in Alzheimer's disease is probably not cerebrovascular in terms of thrombotic occlusive disease, but may relate to axonal degeneration. And this is, of course, a big problem. Of course, radiologists always say, oh, it's vascular disease, even when they have never had hypertension, never had diabetes. We have lots of white spots. So the white spots probably are just from Alzheimer's disease, but they don't relate to the REE in the sense that REE doesn't, when it resolves, there's no extra white spots. So probably that edema doesn't cause any particular axonal degeneration because there's no atrophy and there's no white spots and there's really no trace other than microhemes if there was hemorrhage.
Okay. And can antiplatelet drugs be given in these patients?
Absolutely. But even anticoagulants can be given. The evidence is very weak for lecanemab that there's any difference in people who did or did not get anticoagulation. And one of those papers I'm a first author on, you can look it up, Honig et al. But also in donanemab, there was really no evidence at all that anticoagulation was harmful. So we don't worry. A lot of doctors worry about anticoagulation because obviously if you're anticoagulated, you're more likely to bleed, period. But in terms of specific risk of the antibodies in the setting of anticoagulation, certainly not antiplatelet, we do not find that to be from the evidence to be a risk.
So there are also a couple of questions about, is there any preference between the two drugs, donanemab and lecanemab? And what's the annual cost? I believe the insurance covers fully in US, isn't it? It's not so in other countries. So what's the annual cost? In India, I think it can cost around 25 lakhs per year.
Yeah.
Which is very highly prohibitive. Even I may not consider it for myself. So.
Yeah. I mean, cost obviously depends on, many drugs are cheaper in India, but not all. This drug is not particularly expensive compared to the anti-migraine drugs or the anti-MS drugs or a lot of other drugs. Obviously, if you're paying for it yourself, it's always more expensive than if the insurer is paying for it. So cost is a tricky issue. I think there seems to be a prejudice, and as cognitive neurologists, we all know there's probably a prejudice against treating cognition. So somehow these ALS drugs can cost hundreds of thousands of dollars and have very little evidence of any efficacy at all, and they're paid for, whereas an Alzheimer's drug that just costs a couple of tens of thousands of dollars isn't. So
Yes.
very tricky. But yeah, I don't know if I answered the question, but it's, did I answer the main question? It was about cost.
Yeah, you have. But what's the preference between donanemab and?
I knew I was leaving off something. Yes, the tricky question. Yes. So they both work. The problem is that donanemab almost certainly doesn't work after 12 or 18 months, and you don't even know when that time is because you have to do a PET scan before you know whether it stopped working or not. So it does make it a little bit less favorable when you look at it that way. Unfortunate that the drug doesn't have the same properties as lecanemab. We have other drugs coming out that will, probably also be valuable. But at the moment, lecanemab was earlier released and has wider approval, partly because of these reasons. So donanemab, for example, is still not approved in Europe. And I don't know if it's been put forward in India as a possible, I don't know whether it's being considered by your authorities, but I know lecanemab is being considered by your authorities. And certainly lecanemab has a lower incidence of side effects and does not have this problem of running out of steam. It does not have this problem that it stops working at some point.
Thank you. Thank you very much, Dr. Honig. I think you've highlighted all the recent advances so beautifully and elegantly and explained all the indications, the contraindications, and the problems in starting the anti-amyloid therapy. And I'm also glad you highlighted the costs and that attitude of neurologists towards cognitive neurology. Even though they take pride in their own cognition, they are not so worried about the patient's cognition. So as you very rightly pointed out, motor neuron disease, even congenital myopathies or muscular dystrophies and all get diagnosed and nobody asks why you are diagnosing them. But when it comes to dementia, they will ask what is the use. So I think it's very appropriately put. And I'm happy that all these disease modifying treatments will soon change that attitude even more. Thank you very much for a brilliant talk. And I think I hand over to Fahim and Atanu for any last minute comments. Thank you very much.
Thank you, Professor Honig, for your excellent deliberation and also answering many of the doubts which our learned audience have raised. And for all those who have participated without asking any questions, who have listened to this great lecture, I thank all the audiences. We sincerely thank Professor Ratnabali Madam for moderating the session so beautifully, and also to the IN and IN President and Secretary, and of course the IN Digital team for helping us to organize this webinar. This was an excellent session for all of us to learn something from all stalwarts in the field of this Alzheimer's therapy, who has personal experience of using these drugs and who has participated in various clinical trials. So with this note, I hand over this to my colleague, Dr. Fahim. And we also like to invite all of you, the neurologists of this country, to our first annual conference of the Cognitive Neurology Association that is going to happen in November between 15th and 16th in Kolkata city. And that I request Dr. Fahim to further highlight what I have left.
I think Atanu sir, maybe you can tell something about CNA. I'm just putting the link in the website. So
Yes.
Atanu sir,
Yeah.
you want to tell something about CNA? I just put the website link in the chat box.
Yes. Yes. Actually, I was trying to talk about the CNA because in last couple of years we tried to form an association dedicated for the cognitive neurologists of this country, because the dementia patients and cognitive impairment patients of cognitive impairment are being treated mostly by the neurologists of this country, and they need a platform. So it is now we are fortunate that we could form an association, and that association is going to have its first annual conference, where many of the experts from the country and as well as from international experts, they will come and they will share their experiences of the different biomarkers, the advancement in diagnostics, as well as the personal experiences of using these drugs from our country as well as from abroad. So we request all neurologists and those who are interested in the field of cognitive neurology to participate. You can go through to our website and get to know about the things happening. And if you register, and please come to and participate in the large number.
Thank you very much, Atanu sir, and thanks a lot, Dr. Honig. A heartfelt gratitude to Dr. Honig for truly a outstanding session filled with full deep insights and practical knowledge and years of clinical trial experience, and that has given us so much to reflect upon. And it's not only informative but also inspiring for all of us to begin to think more critically about how such emerging therapies can be adapted and implemented in the Indian context when we have so many vascular risk factors that we were talking about. And at the same time, I'm looking forward to, and all of us, in fact, are looking forward to meeting Dr. Honig. He's going to be coming in the Indian Academy of Neurology conference to Banaras this year. So look forward to meeting you there in person, sir. And at the same time, grateful to Dr. Ratnavali madam for skillfully moderating the session and guiding the discussion with a lot of clarity and depth. And finally, thanks to the IN office bearers, our president and secretary, and the IN technical team and all the audience who have joined us today. And we look forward to your continued conversations in advancing this Alzheimer's cure and dementia in future webinars to come. Thank you very much and have a great day. Thanks everyone for joining.
Thank you, sir.
I think you can conclude the session. Thank you. Thanks, Dr. Honig. Thank you, madam.
Thank you. I would like to thank both of you for inviting me, and Dr. Honig, it's a privilege to listen to you. And so my only comment is that if you're doing biomarkers in your centers, it would be nice if you could share that information with other centers, because can we provide samples and will we get results? So I think there were some questions like that in the chat box, so it would be helpful to everybody. So please share that information if that is available for patients or for researchers to send the samples to your centers.
Yeah.
Done.
Yeah.
Thank you.
Thank you very much.
It's really a pleasure seeing you all. Thank you so much for inviting me. And I know, thanks for all the great questions. I'm always impressed with you and your colleagues. I realize it's a different work environment, but on the other hand, we experience the same problems.
Thank you.
Thank you.
Okay, bye-bye now.